Hello everyone.
Hello, sir. Good afternoon. Good evening.
Myself, Dr. Vinod Kaushik from IIP Digital Media Team. I will be the host for the today's webinar on lower limb alignment in the kids and related issues with resource person Dr. Pratish Singh being organized by IIP Haryana, Faridabad District webinar. The Indian Association of Physiotherapists is the oldest and the largest association representing physiotherapists in India since 1955. The IIP digital media team consists of a group of physios who handle Zoom platform, webinar, live streamings, and IIP profiles on social media platforms Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow IIP profiles on these social media to receive notification for our events such as webinars, workshops, CMEs, conferences, health camps, blood donations drive, and to know about recent updates on physiotherapy. Subscribe to IIP YouTube channel for notification of our live webinars. In playlist section of this channel, webinars are segregated into various folders on topics like orthopedics, neurology, sports, and fitness, pediatric, cardiopulmonary, women's health, research, cancer, rehab, etc. For easy access, the social media links will be shared in the chat shortly. Thanks a lot for patiently listening to me, and I will hand over today to our moderator, Dr. Sakshi Sachdeva. She will introduce about our today's speaker. Please, ma'am, continue.
Thank you, sir. Today we have our speaker, Dr. Pratish Singh. He's a senior consultant and professor, pediatric orthopedics, deformity corrections, and Ilazarov surgeries in Amrita Hospital, Faridabad. Amrita Hospital is one of the largest hospitals in Asia with multi speciality, inaugurated by our PM, Shri Narendra Modi ji. Now, I'll please hand over to Dr. Tish Singh to continue and start with the session.
Thank you, ma'am, for such a kind introduction. Thank you, Dr. Vinod Kaushik sir, and IIP Faridabad and other teams of IIP for allowing me this opportunity. I will do my best and to add to your academic programs. Uh, I will share my screen right now. Okay. May I ask Satya ma'am, my slide is visible or not, ma'am?
Yes, sir, it is visible. Single slide is visible.
Okay, ma'am. Thank you. So, I chiefly deal in pediatric orthopedic patients and deformity corrections. So very often we come across patients or parents or even say our colleagues where they are concerned about uh, alignment of lower limb, that whether limb is normally aligned or there is some abnormality of limb. So the common concerns are usually whether there is bowing of knees or there is knocking of the knees or there is some bowing in the legs also. So bowing in the leg and bowing in knee, it is different. Sometimes they are concerned about in-toeing and out-toeing. So in-toeing means the patient is walking like with foot twisted slightly inward, or sometimes the child walks with a wide based gait rather than a normally placed foot, in which we place our foot in a position to each other. And sometimes the kids are say almost every kid is more say comfortable in W sitting rather than conventional cross leg sitting or normal sitting. So these are the common concerns and alignment related issues which parent asks for parent task, or even they come to they come in our day-to-day OPD practice. So again, with respect to hip, there are another common problems, whether hips are normal or abnormal. There is abnormality in the hip, or there is flat foot is there or not. If it is there, then how to diagnose it and what are uh, what are the problems associated with it, or any other deformity of foot, or say, for example, CTV or cavus foot or calcaneus foot. So these are the common concerns. So we will take these aspects one by one, and I will show you what is normal and what is abnormal. So regarding bowing of legs and bowing of knee. Hello, am I audible, ma'am? Hello.
Yes, sir, you are audible.
Okay, ma'am. And slide is changing, ma'am.
Sir, actually,
Yeah, sir, it's changing. I am able to visible. It's like very much clear.
okay, sir.
Okay, ma'am. Bowing of legs and bowing. So there can
Yeah.
be bowing of legs and there can be bowing of knees also. So both are slightly different. So when bowing of knee means deformity is occurring at the knee level, and bowing of legs means the tibia is deformed. So in usual scenario, tibia has to be straight, and tibia femoral angle in adults is 7 degree. So with respect to femur, the tibia is in valgus angulation with respect to of valgus angulation of 7 degree with respect to femur. But in case of a neonate or any child who has not started walking, so before age of 12 months, a patient will have bowing of legs or genu varus. So this genu varus alignment is physiological in a child with less than 12 months of age. So this alignment keeps on changing, and in a patient with, say, after 18 months to 2 years, this alignment will convert to normal adult alignment like genu valgus alignment. So this varus alignment or bow leg, it is more apparent in kids because they are slightly chubby. Their fat distribution is more in the lateral aspect of leg. Additionally, the muscle mass is more on the leg aspect, on the lateral aspect, because medial side of there is no muscle on the medial side of tibia. The anterior muscles and lateral bulk of and the lateral compartment muscles, tibialis anterior and peroneal, both peroneal longus and peroneus brevis, they occur on the lateral side and they add to mass of the leg on the lateral side. So that's why there is false appearance of bowing of leg. So it is not a true bowing, but that is a false appearance. So once when I when I when we say how this alignment changes from a say neonate to a new walker to a toddler and to adult. So this leg alignment keeps on changing. So a baby is born with bow legs. This bow leg persists for around 18 months. So when child starts walking, the bones get strength and this alignment starts reversing towards adult alignment. So at the age of around 18 months to 2 years, this alignment becomes neutral, means tibia and femur, they have 0 degree angle. So as against normal angle of 7 degree in adults. After say 18 months or to 2 years, this genu valgus alignment, it accentuates in such a way that tibia femoral angle becomes 10 degree. So this 10 degree is the apparent valgus. So again, although it is physiological, alignment is physiological, but it may be perceived as genu valgus. So in a patient with age of 4 years, the genu valgus alignment is up to 7 degree, up to 10 degrees counted as normal. And then again, after say 4 years to 8 years of age, this genu valgus alignment, it reverses again slightly. So the tibia femoral angle of 10 degree, it will reverse to around 7 degree. So this is a normal progression of alignment from say genu varus or bowing of legs to genu valgus, and maximum genu valgus at 10 is 4 years of age, and the adult alignment is reached at 8 years of age. So if there is variation outside this these alignments, then that is pathology, and very some delays in this transition of alignment. And for example, in a patient with malnutrition, and or patient has delayed milestone, or patient has not walked on his legs for long duration. So there can be some variations, but these variations occur only for say around 5 to 6 month delay or delay. But there cannot be say very long delay of years in changing these alignments. So how will you decipher that this bowing is pathological or physiological? So other than cover test, we will cover the apex of deformity and we will try to observe the knee. So if we see that knee is slightly valgus with respect to femur, so then that is a normal alignment. That's a normal alignment. Because in say adults after 2 years, or even in kids after say 18 months to 2 years of age, the tibia is in valgus angulation with respect to femur. So if we cover apex of the deformity or the middle part of leg, and we observe angulation of thigh with respect to and angulation of proximal part of leg. If it is valgus, then it is normal, and if it is not valgus, there is it is varus aligned or medially aligned, then it is abnormal. So this is a simple clinical test, and these findings may be reconfirmed with the help of radiology. So we can get X-ray of the patient, and with X-ray, these things become more clear. So what are the red flags in the knee alignment? So means they are always pathological. They are not normal. So if a patient has persistent genovirus, means genovirus beyond 18 months to 2 years of age, a patient has asymmetrical alignment. One side is genovalgus and other side is normal, or one side is genovirus and other side is normal, then it is always pathological. If patient has deformity in with limb length discrepancy, means one limb is either short or one limb is long, then it is always pathological. Or sometimes another variant is tibia vera. So again, it is a variant of genu verum or bow leg. So usually in adolescent patients. So that is always a pathological. So with respect to say intoing of gait, so this intoing is often it, and it is physiological in a patient with up to age of say 4 to 8 years of age. So if a patient is walking with toes inward, then it shall be counted as normal. So this intoing is contributed by two factors. First, there is tibial intorsion. The tibia is twisted inward, and there is femoral anteversion. So tibial intorsion means the distal part of tibia is twisted inward with respect to proximal part of tibia. Just a minute. I'll seek some small break. Just a minute, ma'am. There is some network issue. Hello, am I audible?
Yes, sir.
Yeah, please. Thank you. So adults usually walk with slight outward deviation. Foot progression angle is outward nearly 15-degree angle. But a neonate or a child up to say 4 years of age, he walks खुला है मेरा रुक जाओ। So he walks with normal foot progression angle is slightly less in case of neonates, while in case of adults, foot progression angle is more, around 15 degree. So this is contributed by two factors, tibial intorsion and neck anteversion. The neck anteversion is high in case of young kids and neonates, while in case of adults, neck anteversion is quite normal, around 15 degree. So sorry. दरवाजा खोलो नहीं रहा है दरवाजा खोलो So when we were talking about foot progression angle, so in normal foot progression angle is around 15 degree outward deviation, while in foot progression angle of in a neonate or a young walker is inward 15 degree inward. And so this foot progression angle defines in-toeing, out-toeing or normal toeing. So this in-toeing is normal till the age of 8 years and it usually resolves till with that age. So this is not a bad gait. So it is itself not be counted as a bad gait. And another factor which I mentioned is tibial torsion. So distal part of tibia is twisted inward with respect to proximal tibia. So in a child is born with a very high tibial torsion, sorry. So this intorsion, it reverses to extorsion in case of adults. And this intorsion may be ascribed to fetal position. So this fetal position or the fetal position is responsible for high intorsion angle. So a new walker or a neonate, say a child of around 1 year of age, he will always have in-toeing gait. And this in-toeing will reverse gradually after say around 4 years of age. And even if it persists after 8 years, then it is abnormal. So usual treatment prescribed is butterfly exercises and simple ambulation. So what are the red flags in case of tibial intorsion? So if a patient is having persistent in-toeing even after 8 years of age, or if this in-toeing is in a patient with cerebral palsy, or if it is there asymmetrical in-toeing, or some foot ankle pathologies like CTV, then it is an abnormal thing. Otherwise, it shall be counted as normal. And femoral neck anteversion is high in case of kids. So this means the femoral neck is pointing anteriorly. So that's why a child tend to walk again with in-toeing gait. Say neonate has around 40 degree of neck anteversion, and this reverses to adult values at around 15 degree up till around age of 8 years. So most of the kids, they prefer to sit in W sitting position. So this W sitting can be attributed to very high neck anteversion angle. So this neck and so the biomechanics around hip, they are in such a way that they feel more comfortable in this W sitting. So we shall not force a child to sit in this position. Say avoid this W sitting position. So even if they continue with this W sitting, then it shall be counted as normal, and this will reverse after as 8 or at the age of around say 4 to 8 years. This will reverse. So what are how will you say screen a hip?
whether hip is normal or abnormal. So a child who can squat, sit cross-legged, and with symmetrical hips movements has a normal hip. So these three postures: sitting cross legs, middle part is say wide abduction, and a child who can sit say uh, squat is a normal. And what are the red flags in the hip position? Means they are against the normal alignment. Means patient has persistently abnormal posture, or asymmetrical abnormal posture, or hip is painful, or abduction or range of motion is asymmetrical or on the both sides. Then these are abnormalities of alignment. Every child will walk with a wide based gait. So this wide based gait is not abnormal, it is normal. So because they have just started walking, so they will always have some sense of falling. So as a protective measure, they will walk with slightly wide based gait, and this is so it becomes a defensive posture. And pelvis is also wide with respect to say body. So the body ratios are in such a way that pelvis is relatively wider in case of young child, and with respect to total height of patient. So again he will walk with slightly wide based gait. So this is also a normal thing. Flat feet. So these are so this is one of the most common concern of every parent or even say routine our caregivers. So a young child will always have appearance of flat foot. So this flat foot may be ascribed to fat distribution in the middle arch of foot. So apparently the bony arch is normal, but the foot appears to be flat because of fat distribution on the middle side of foot. So uh, so these foot can also be counted as normal rather than abnormal. So this arch or the fat component, it starts decreasing with the age, and when the bones grow in size, the arch becomes apparent. So even if a child is having say flat foot after even say 8 years, then it is counted as pathological, or otherwise it do not require any treatment, or even no shoe or no brace also. So a flat foot is a normal variant of a foot rather than abnormal. So which flat foot require treatment? So these so these flat foots, they require treatment. First, a rigid flat foot means a painful flat foot or a flat foot with decreased mobility of subtalar joint. So they require medical attention, and they require some treatment also. Otherwise, they don't require any treatment. And this nearly 4% of population has flat foot, but usually they are flexible. Just to say just a lighter moment, very famous personalities, they have flat foot. The Usain Bolt, the fastest man alive around till last Olympic, he has flat foot. The famous footballer David Beckham, he was also having flat foot. So how will you check that whether the arch is there or not? Simply elevate the great toe. So the arch will be apparent. So the windlass mechanism of foot will be activated, and this arch will be visible. And even additionally, we can ask the patient to walk on his toes. So if a patient walks on his toes, then the arch will be more apparent. So if this thing is there, we can safely say that a patient has flexible flat foot rather than he do not have any gross pathology of the foot. And we can check movements of subtalar joints by moving the heel medial ward and lateral ward. So heel alignment. So the heel is slightly neutral to valgus in a patient. In case of flat foot, this heel is slightly valgus, slightly 5 to 6 degree of valgus with respect to ankle or calf. But and this will reverse to neutral alignment on toe walking. So these are the normal thing. If there is any deviation outside this, is persistent valgus even on toe walking, it signifies that subtalar joint has reduced mobility and there is pathology. Even if the valgus is excessive more than 6 degree, then it is also abnormal. So red flags or say in the flat foot or which are abnormal foot means if a patient has bean shaped foot means there's concavity on the sole of foot, then it is it may be congenital vertical talus and it is always pathological. If there is asymmetry in the foot alignment or ankle alignment, then it is always then it is abnormal. If patient has painful foot, then it is a problem rigid flat foot, or a previously normal foot which becomes flat or which changes position to valgus aligned ankle, then it is also a abnormal thing, it is not normal. Then another variant is club foot. So this is deformity of foot, ankle, and leg. The calf is spindle shaped, thin, and less muscular with respect to a normal calf. And patient cannot dorsiflex the foot. So there are four cardinal deformities: forefoot adduction, heel varus, cavus, and equinus. So if these four cardinal deformities are there, then it may be labeled as club foot. So yes. So how to exclude CTV in a newborn? So very often you will come across questions from parents that this baby has club foot or no. So we can simply scratch on the sole of foot. If foot goes in dorsiflexion, then it is surely you can simply exclude this club foot. Means baby do not have any club foot. Or if there is active dorsiflexion is possible, then also it is not club foot. So a club foot patient cannot dorsiflex the foot. And so yes, so this is the way how to exclude CTV in a newborn. And these sure short signs of CTV are medial deep crease, heel is not aligned with respect to calf, and dorsiflexion is not possible. Yes. Sometimes a newborn may have this shape of foot, means calcaneovalgus foot. The heel is pointed downward and foot is dorsiflexed. So again, this is a postural problem, or it is not pathological. It is due to intrauterine position of the baby, and it will reverse in a couple of months. So 1 to 2 months. Just a minute. Just so sorry. So this will reverse. So this calcaneovalgus foot is due to unfolding of problem. Unfolding. The baby is intrauterine, means baby is folded inside his intrauterine position. So gradually this baby will unfold. Legs, knee extension will gain. Initially there is fixed flexion deformity of knee. So this the deformity will also improve. So these things happen. So this calcaneovalgus foot will also reverse in a due course of time. There was a problem. Sometimes there can be bowing of tibia. So this is also a benign problem and not a problematic problem. So usually this bowing is posterior bowing, and usually in concurrence with the calcaneovalgus foot. So this will also reverse in a due course of time. Sometimes there is bowing is on the anterolateral side. So this anterolateral bowing is always a pathological. It is not benign. So this may be due to congenital pseudoarthrosis. So bowing which is on the posterior side is safe. Bowing which is on the middle side is safe, but posterolateral bowing is always a pathological bowing. So for example, this patient was having anterolateral bowing, and gradually it progressed to this phase, full-blown congenital pseudoarthrosis of tibia. So this is how this CPT or congenital pseudoarthrosis of tibia is treated with limb lengthening and excision of pseudoarthrosis of tibia. So just to conclude, majority of parental concerns in neonate are normal. For example, flat foot, calcaneovalgus foot, or bowing of leg, bowing of tibia, white based gait, flat this. So these are normal. but we need to be vigilant for red flag signs. Means we need to be able to decipher what is normal and what is abnormal. Thank you. Any questions?
Thank you very much, sir. Dr. Sakshi is there.
Yes, sir. Thank you, sir. It was a very informative session. And
Yes.
special thanks to IIP Faridabad team for organizing such events, and also to Dr. Vinod Kaushik, sir. The chat box is open among the participants for any questions to be asked.
Otherwise, we can go ahead that all the queries I will discuss with the sir if someone asks in the chat box. Okay.
Yes, sir.
On the IP YouTube channel, they can also ask the questions. Okay.
Sure,
Okay,
sir.
sir.
Thank you very much, sir. Thank you. I'm just
Okay.
winding up this. Okay, sir.
Yes.
Thank you.
Thank you,
Thank you,
sir.
sir. Thank you. Thank you, sir. May I leave now, sir?
Yeah, sir. Yes, sir. Sure.
Thank you, sir. Thank you.